Welcome back, everyone. If you're prepping for the CPC exam, well, you already know it's an absolute marathon, right? It tests not just your medical knowledge, but your procedural discipline under serious pressure. So today, in part 18 of our 100-part series, we're tackling the beating heart of diagnosis coding, the 5-step safe ICD-10-CM coding workflow. Oh, and real quick before we jump in, make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, let's dive right into this. So think of this 5-step safe workflow as your ultimate defense mechanism against the exam. It is literally a bulletproof, repeatable procedural playbook designed specifically to keep you from failing. Because let's be honest, when you're staring down that grueling 4-hour test, you absolutely cannot rely on guesswork or just muscle memory. You need a system that forces accuracy every single time, totally stripping away the anxiety of taking a wrong turn. And this specific 5-step roadmap, this is your procedural anchor. The CPC exam heavily, and I mean heavily, tests your index to tabular workflow. I really want to establish right now that missing just one of these steps in this exact sequence can completely ruin your exam score. Skipping around, yeah, that leads straight to invalid codes, truncated characters, or missequencing rules. So let's break down exactly how to execute this flawlessly, from start to finish. Step 1 starts in the Alphabetic Index, Volume 2. Here is your hard and fast rule. Always locate the main term by searching for the condition or disease process. Imagine a patient rolls into the emergency room with a fractured femur. Do you look up femur? No way. You look up fracture. The golden rule of diagnosis coding is identifying what is actually happening to the patient, not just where it's happening anatomically. Okay, so once you've got your main term, like fracture, we move to step 2, checking and reviewing the indented subterms. This is where you really drill down to capture the precise clinical picture straight from the provider's documentation. The code set is going to constantly prompt you for specifics. Was that femur fracture traumatic or pathological? Is it acute or chronic, left side or right side? If the provider documented a highly specific descriptor, the exam fully expects you to capture it right here in this step. Now, the absolute most crucial point in the entire process happens right here at step 3, verifying in the tabular list, volume 1. Stop and read. Tabular verification is completely non-negotiable. This is exactly where amateurs fail the exam. An index code is totally invalid until you meticulously verify it in the tabular list. The index, it merely points you in the general direction. The tabular list dictates the final legally binding validity of your code. When you're verifying in the tabular list, you have to follow the instructional notes closely. Take a look at the really dangerous trap of excludes 1 versus excludes 2. Excludes 1 means not coded here. You literally cannot code those conditions together. Like you generally can't code a congenital anomaly and an acquired version of the exact same condition together, it's a hard stop. Excludes 2, however, means not included here. That means both conditions can legally exist in the same patient, and you can code both if the documentation supports it. You've also got to watch like a hawk for sequencing directions, like code first and use additional code. Moving right along to step 4, we check the guidelines and finalize characters. Certain chapters, especially the ones dealing with injuries and obstetrics, require a mandatory 7th character. Let's go back to our femur fracture patient for a second. An A in that 7th slot would denote their initial ER visit, while a D tracks their subsequent encounter, say for cast removal, and an S indicates a sequela or a late effect. And hey, if your base code is only 4 or 5 characters long, you are required to use the placeholder X to push that 7th character into the exact right slot. There are absolutely no exceptions here. Finally, we wrap up the whole workflow with step 5, final code checks and audit proofing. Master coders always verify the highest level of specificity. If the doctor's documentation clearly states right arm, you can't just pick an unspecified side code just because you're in a rush. Relying on not otherwise specified or unspecified codes when the provider handed you the exact details, we call that a lazy coding error. And in the real world of medical billing, these unspecified dumps are major audit triggers that will get your claims swiftly denied. All right, let's do a rapid-fire summary. Lock this 5-step checklist into your memory right now. 1. Index the main term condition. 2. Drill down into the specific subterms. 3. Stop and verify in the tabular list. 4. Check for mandatory 7th characters and placeholders. And 5. Perform a specificity audit to make sure you aren't leaving any documented details on the table. Use this mental cheat sheet as your ultimate study guide, and you're going to stay incredibly safe on exam day. If you follow this workflow, you protect yourself from the vast majority of traps built into the CPC exam. Next time, in Part 19, we're tackling some of the most complex guidelines in the whole book: infectious diseases, strict HIV sequencing rules, and navigating the infamous neoplasm table. But ask yourself this: if this 5-step workflow is your ultimate safety net, what happens when a single infectious disease guideline legally forces you to read the rules in reverse? We will decode that mystery next time. Until then, keep practicing, and I'll see you in the next explainer.